Hello everyone, welcome to another edition of Cosmetic Corner. I'm Chris Surek, your moderator, and I'm joined by Dr. Alghoul, faculty at Northwestern University, clinical editor and a board member of ASJ, and also president-elect of the Midwest Association of Plastic Surgeons. We're joining you from our regional meeting today to do a live version of Cosmetic Corner to talk about a very interesting article that's right in the wheelhouse for Dr. Alghoul. The article is focusing on minimal incision vertical endoscopic lifting for lower eyelid malposition. And I want to commend the authors. It's a very interesting topic about expanding the indication of endoscopic surgery to treat lower eyelid malposition. And I particularly asked Dr. Alghoul to do this because he has really good expertise in the area of periocular surgery. And he's actually developing some of his own concepts in regards to the lateral shaping of the brow and the eyelid. And so, Dr. Alghoul, my first question for you is, tell me about the article. What kind of value can we take from this article?
Well, this is a single surgeon series, Dr. Francesco Bernardini, who's an oculoplastic surgeon from Italy. And, the interesting thing about this article is that he's using endoscopic technique to treat lower lid malposition, which I think is very unique. So he talks about the superior complex of the periocular area, which is the brow, and the upper eyelid. And then he also extends his ability to mobilize the inferior complex of the periocular area, which is the lower lid. But really what he's really moving here is the lateral canthal complex, or the lateral orbital area. I think what's really neat about this article is his ability to dissect the lateral canthal area endoscopically and even divide the lateral canthal tendon, and with that, being able to mobilize the upper and lower lid as one unit, in addition to mobilizing the midface and obviously doing the same endoscopic fixation. He shows that this really improved lower lid malposition, which I think is very neat. And you contrast that with what we do usually with an open technique, where we do a transpalpebral midface lift and midface fixation. But then I think what's also important when you contrast this to the classic lateral canthoplasty procedure, which is like a tarsal strip, where you divide, you do a canthotomy and canthalisis, and you do a tarsal strip. And that procedure really has its own limitation as well. You can get beautiful results on the table, but eventually you will get a relapse of that laxity in the lower lid, and also you get a lot of lateral canthal webbing, which is kind of very common with this procedure. So I think it's very neat that you can endoscopically be able to mobilize the lateral canthus and fix lower lid malposition without dividing the lateral canthal tendon and just doing it endoscopically.
Yeah, you're absolutely right. I mean, there's a deconstructive component as you then reconstruct the canthus with traditional method.
Exactly.
And here, this minimally invasive technique, if you will, expanding the endoscopic indication. But that's where the anatomy gets very important. Exactly. Before we get to the anatomy, though,
yes,
I know that you have some critiques or just some thoughts about the article itself. Can you tell us a little about that?
Yeah. So I think the great thing about the article is the video, especially video 3, is really that's Absolutely. Where the money is. And if you want to navigate through this paper, so we're going to help you navigate through this paper. So video 3 is very important. It really shows you how he's able to kind of mobilize the lateral canthal area very nicely. In addition to that, I think the 2 pictures that were picked for the printed version, they don't do this paper any justice. You really want to look at the supplementary figures, because it really shows beautiful before and after pictures. And I think this is really where the results are believable, right? Yeah. Because you really want to see good results. However, my main critique for this paper is that they really didn't use any objective outcome measures, which are readily available and they're very easy to do. However, they're a little bit labor intensive. So you can standardize all these pictures and you can do actual measurements to really show that there is a difference between before and after. So they really relied on rating, both the surgeon's rating and the patient's doing a visual analog scale, which wasn't very clear in this paper. However, they looked at the lateral canthal position, the lower lid margin position. They looked at the canthal tilt. They also looked at scleral show, and these are all things that can be measured. So there are objective measurements like measuring scleral show, measuring the canthal tilt,
right.
And also you can measure the MRD2 distance, which is the distance between the pupil and lower lid margin centrally and laterally. That can actually show you, and I'm sure that Dr. Bernardini would have been able to show a difference. And the other critique I have is just the design is a little bit confusing. For example, they have 3 groups.
Right.
The first group, they had lid laxity, involutional changes. Second group had cicatricial ectropion. third group really didn't have either.
Right.
So why did he include the third group? Well, I think they included a third group as a control. So the way I understood that this article is that they didn't do the endoscopic technique in the third group, they only did blepharoplasty. But yet they don't really compare the three groups together. So if you have a control group and yet you're not going to compare it to the other two, so then why did you include it?
Right. Excellent points. Very thorough evaluation, though. This is what I love about Dr. Alghoul. He really looks at the science critically. Now, let's get to the anatomy. Okay. The first thing is the Canthal complex. We hear all these different types of terminologies. So I kind of want you to walk us through how you see the Canthal complex anatomically, so that we can kind of educate and try and get some terminology correct here, because it can be challenging.
Absolutely. I mean, I think you're right. There are two things here to kind of clarify. So if you're really not familiar with the lateral canthal anatomy and you look at this video, you're really going to be completely confused because the terminology in the paper is also confusing. So Dr. Bernardini, when he's elevating the orbicularis, he does say the orbicularis, ligament, but then he said, well, no, it's really the orbicularis attachment to the lateral orbital rim, and that's really your lateral palpebral raphe. So he's starting with that, and then he mentioned something about the retinaculum, and I believe what he is pointing to as a retinaculum is the area, that structure described by David Nyes, which is a superficial lateral canthal tendon. It's an extension from the septum and it inserts right on the periosteum. So he's elevating that next. And then finally, he talks about the lateral canthal tendon, which is a deep structure, and he actually divides it, and he shows you, okay, this is completely divided. So he's really dividing the three layers of the lateral canthal complex, and he's just completely mobilizing, that area. So that's kind of where the terminology is, because he really does use the word retinaculum. He uses the word lateral canthal ligament at some point, and then he uses tendon. So that can be confusing.
Absolutely.
The second point I think that was interesting, and I don't know, I want to get your thoughts on that, is what did you think about that lateral fat pad in the upper eyelid?
Right. Well, we're both passionate anatomists, and we talked about this a little bit when we were prepping for the interview. I would agree. He talks about this, there is an upper lateral fat pad in the lid, and I find that hard to visualize, and I think based on looking at the videos and talking about it that it's also synonymous with Eisler's fat pad. So I think we got to be careful adding a third compartment to the upper lid, and that very well might just be Eisler's fat pad.
And I totally agree with you. I mean, we open the upper lid all the time, and the central fat pad extends laterally. However, from that limited endoscopic view in that area, I mean, the fat that he's pointing to, I mean, it has to be the Eisler's fat pad because it's right there, and actually you use that fat pad as a landmark to locate the lateral canthal tendon. So
Absolutely.
I think that's what he's pointing.
All right, so one final question. Let's talk about candidates, okay? In your opinion, clinically, for us, when we go out into our practice and implement potentially utilizing this process, who are the candidates for this procedure?
So that's a great question because it all comes down to candidates and patient selection, right? So it's very interesting. So in group 1, they insist or they really emphasize the point that it has to be mild lower lid laxity, right? So they don't really define that very well. And that's very important because people have these early involutional changes in the lower lid, and that's kind of the group. They really don't tell you how to select that patient group, and based on, I mean, we all know the snapback disc, the lower lid distraction. So this is kind of where it becomes a judgment call because it doesn't seem that this procedure will work very well with someone who has severe laxity, because I guess that's the type of patient you're gonna do your conventional lid shortening procedure. The other thing I think is very important is that the cicatricial ectropion, I mean, there is a wide range of patients presenting with cicatricial ectropion. The last picture that he shows, I think it's figure 7, the supplemental figure, he shows a very significant cicatricial ectropion. He shows beautiful correction actually with that. But it gets a little tricky. He's not using a spacer, okay? And instead of that, I think he's relying on the CFI, which is that superficial enhanced fluid fat injection, combination of derived adipose-derived stem cells and platelet-rich plasma, and I think he's using that to augment the volume of the lid and kind of replace that volume deficiency that you get with the cicatricial ectropion. So I think that's a fascinating concept. However, it would be. I think that's one of the things that is not clear in this manuscript is that the degree of the cicatricial ectropion, and because some of the pictures you showed, there is definitely retraction and beautiful correction. but is this procedure really for everybody?
Right. Excellent point. Well, Dr. Alghoul, thank you so much for being here.
Thank you for having me, Chris.
We really appreciate it. It was a great discussion. We encourage you to look at the article and definitely check out the supplemental figures so you can get a really good view of that. And the videos are fantastic. And we'll see you guys in the next edition of Cosmetic Corner. Thank you.
Thank you.